This video presentation is about shoulder pain, how to make the diagnosis. I am Mayor Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. The objectives are to develop concepts of correlation of anatomy, injury mechanism, physical exam, and imaging to make the correct diagnosis. We will show case-based examples of shoulder disorders, and I'm going to emphasize the importance of making the correct primary diagnosis that will improve patient outcomes and management of shoulder pain patients. When we think about the differential diagnosis of shoulder problems, you have to think, what joint is it, what space is it, or is it referred pain? There are three joints about the shoulder: the glenohumeral, the sternoclavicular, and the acromioclavicular. Oftentimes the mechanism of injury can be one single event, such as a dislocation, an acromioclavicular separation. We also have spaces: the subacromial, the scapulothoracic spaces. The subacromial space is between the rotator cuff below and the acromion clavicle CA ligament above. There's a bursa sac on top of the subacromial, on top of the rotator cuff in the subacromial space. And problems here are oftentimes repetitive, as in a subacromial bursitis, more of a compressive type problem. Another diagnosis, subacromial bursitis. Others refer this as impingement syndrome. However, that doesn't describe the specific entity of what structure is involved and what the problem is. Is it inflammation? Is it tear? Partial tear? The scapulothoracic articulation in the back can also have some bursal irritation, some popping. Always look for, when you examine a patient, the scapulothoracic movement, the synchrony of it. Is it symmetrical? There can be issues that start at the neck and involve the scapulothoracic articulation. Oftentimes with shoulder problems, the shoulder problem starts first. Then there is scapulothoracic winging or a sick scapula or an asymmetry of the position of the scapula. So never forget the scapula and examine the scapula in addition to the shoulder. Referred pain. Typically this is repetitive, no specific event. There can be referred pain to the shoulder from the neck, a cervical disc problem, from the scapula. From the lungs, you can have an apical tumor in the lungs that will give shoulder pain. You can also have rib problems, such as a stress fracture of the rib or a cystic problem with the rib. I've seen a couple of aneurysmal bone cysts that refer pain to the shoulder. So if it doesn't seem typical, think about a referred pain from the neck, lung, ribs to the shoulder. Functional anatomy, the joints, the glenohumeral joint, or what we would term the shoulder joint, the acromioclavicular joint, the AC joint, the sternoclavicular joint, and then the two articulations or spaces, scapulothoracic and subacromial space. In striving to make the primary diagnosis, you've got to name the involved structure. We can go with certain odds. In age groups less than age 30, most likely the diagnosis is going to be initially instability as a primary diagnosis. They may end up having rotator cuff weakness, but the primary diagnosis or the underlying problem is most likely instability or something to do with the capsule or the labrum, such as a slap tear. 50% of slap tears have instability. In the older individuals, older than age 40, think about the rotator cuff as being the primary problem, not instability. We get a little stiff as we get older, so it's not an instability issue. More of a rotator cuff dysfunction, typically a compressive rotator cuff problem from above, a subacromial bursitis, compression problem, or a partial tear or tear. And then think about the diagnosis also. Is it inflamed? Is it torn completely or partially? Is it sprained? Or is it instability? And then think about the direction of the instability. Is it anterior, posterior, multidirectional? Laxity becomes instability when they visit the doctor. The muscle groups which stabilize the scapula are the extrinsic shoulder muscles, most of which insert directly into the scapula. The latissimus dorsi and pectoralis major have indirect action on the scapula through their attachments to the humerus. The scapular stabilizers can be divided into elevators and depressors, upward and downward rotators, and protractors or abductors, and retractors or adductors. It is important to understand these muscles and the way that they stabilize the scapula is oftentimes you can have scapular dyskinesis, which must be addressed before a shoulder problem will improve. Oftentimes, the scapular winging in athletes is secondary to a shoulder problem. Elevators and depressors of the scapula are shown. The chief elevators are the middle trapezius, levator scapula, and the rhomboids major and minor. The chief depressors are the latissimus dorsi, pectoralis major, lower part, and there are also accessory depressors, as seen on the front view on the right side of the screen, serratus anterior, the lower part, pectoralis minor, subclavius, and the lower part of the trapezius. As shown centrally in this primal diagram, elevation and depression of the scapula. So the elevators as shown in the diagram on the left, and the depressors as shown in the diagram on the right. These muscles must be acting in synchrony to balance the scapula and create the firm, stable base that is needed for sport. The downward rotators of the scapula. Chief is the middle trapezius and the serratus anterior. The chief downward rotators, shown on the right from the back, levator scapula, rhomboids major and minor, pectoralis minor. There are also accessory downward rotators, pectoralis major, lower part, and the latissimus dorsi. We do see neurologic stretch injuries. The long thoracic nerve palsy would create serratus anterior involvement and scapular winging. The protractors and the retractors are shown. Protraction of the shoulder is actually abduction. The chief protractors are the serratus anterior, pectoralis minor. Accessory protractor is the pectoralis major. The retractors are trapezius, rhomboid, major and minor. Accessory retractor is the latissimus dorsi. Oftentimes we'll see the scapula go into a protracted position with a thrower, which is secondary to a rotator cuff problem or a labral problem usually. So check the scapula for symmetry and think about relative weakness of the retractors causing the scapula to go into protraction and internal rotation, moving away from the spine. Also the abduction and adduction of the shoulder involving these scapular stabilizers, as well as the latissimus, deltoid, pectoralis major. And flexion and extension of the shoulder. This moving diagram makes us appreciate the importance of the synchrony and the agonist-antagonist function of the muscles that must work in balance, or injury will occur, particularly in a repetitive overhead athlete, whether it be throwing, landing on the upper extremity, or swimming. Clinically, a good way to check for scapular winging is to have the patient do a push-up on the wall. You can see as depicted here, the left scapula is shown winging, indicating weakness of the serratus anterior, involvement of the long thoracic nerve. The reported range of segmental innervation is C5 through 8. Usually it's C6, so this would be a neurologic problem, and there is significant amount of wasting and asymmetry when you examine these. Again, in athletes, oftentimes the winging is a bit more subtle, with the muscles appearing to be normal without atrophy, but there's a change in position of the scapula, particularly the scapula goes up into forward flexion, protracted position, and you can also use the seated dip, half Nelson, and vary wall push-ups. We should have patients reproduce their symptoms. If they need a golf club to do that, if they need a prop, whatever they need, a bat, have the patient show you what's popping or what their symptoms are, particularly if it is a repetitive overuse problem. If the scapula is unstable, shoulder problems will result. So this is which comes first, the chicken or the egg? Oftentimes, in my experience, the shoulder problem comes first, and then the scapula compensates for that problem. The glenoid is connected or is in the same bone as the scapula. So if you have an instability problem, there can be scapular movements to allow for better stability with the glenoid staying underneath the proximal humerus. It has been said that an unstable scapula is similar to firing a cannon out of a canoe. It's not going to be very effective, and if you're a thrower or a tennis athlete, if you have abnormal scapular mechanics, your shoulder will end up having some problems such as a labral tear, rotator cuff tear, or problems with instability. So remember the scapula. There can be tightness anterior. Patient can be in a forward head, such as looking at all the devices we're using these days, or in a computer situation where you're in that forward head, increased thoracic kyphotic position. This can lead to overdirect developed pectoralis if they're doing a lot of weight lifting, tight anterior capsule. When we assess the scapula, you can do a command of have your elbows put into your back pockets and try to touch the medial borders of the scapula. Doing shrugs is also important. Working on clockwise and counterclockwise movements of the scapula. Have the patients visualize that their scapula is like a clock face and have them rotate it 10 times clockwise and then counterclockwise. Again, engaging all the scapular musculature in the back, which need to be balanced, of the serratus, trapezius, and rhomboids. The individual had had a left shoulder labral repair. He comes in with pain in his left shoulder about 8 years after his surgery, stating that it felt like it was before. We asked him to demonstrate his complaints. He's a golfer, a right-handed golfer, so you can see how his scapula is winging. And this was actually a primary problem with him. His shoulder was really okay and didn't have any evidence of a re-tear of his labrum. But you can see these tests that we do where we have them do a palm press in front. See how protracted forward and elevated the scapula is compared to the opposite side. You can have them put their hands on their waist and have them push back towards you. Not as obvious an asymmetry. Maybe the scapula is up a little bit. And then if you have him do his swing, he will very well demonstrate the scapular winging that he's experiencing. So working on his scapula allows him to have full recovery and return to his sport. If we just looked at his shoulder, he would not have improvement. So remember to examine the scapula in all cases. That's usually what I start with before I start with the shoulder. Similar to the anterior knee problem, we don't do knee exercises initially. We start up at the hip. Well, if you have a very inflamed, irritated shoulder, if you start with the shoulder and don't address scapular mechanics, they're going to get worse. So think about addressing the scapula before really vigorously working on strengthening of the shoulder musculature. Also in a pitcher, you have to think about contralateral problems with their hip, of hip weakness, core weakness, hip abduction, external rotation weakness. So here our cannon and our canoe. So if you don't have a stable base, it's like firing a cannon out of a canoe. Your shoulder is going to break down and get worse if the canoe isn't stabilized, or put the cannon on the ground. Also another analogy is like trying to crack a whip if your feet are not on the ground. So you have to have a stable base from which to start overhead activities. Is pain referred? Is it coming from their neck, scapula, lungs, ribs? Is it a tumor? Do they have night pain? So if it's a pain that isn't quite classic, make sure that you do a thorough exam of those body parts. This is a neurologic problem. He had a suprascapular nerve stretch, came in with shoulder pain. And again, look at the asymmetry. It's his right side. You can see where there is a concavity or a hollow in the scapula. He was doing 20-pound dumbbell presses, flies, and developed a suprascapular nerve stretch injury. His shoulder does hurt because his supraspinatus is weak, but it's from a neurologic stretch injury, and this is a young college student who shouldn't have that amount of atrophy. So if you have him do a dip, he has difficulty doing this, and you can see the significant difference in the size of the scapular musculature in the scapula laterally, which is his supraspinatus and his infraspinatus. When we have him do a push-up against the wall, again, more the asymmetry of the left, where the normal muscle is bulging out in the scapula and the right. Testing him neurologically from the front, doesn't look very happy, but he is neurologically intact, other than his C5 suprascapular nerve that was confirmed by an EMG, nerve conduction velocity, normal spine films, his cervical spine, as well as shoulder films. He improved with relative rest and avoiding a stretch type mechanism of heavy overhead weightlifting activities. We think about muscle testing. This is a very detailed chart, but I think it's a good one to understand and know that you can refer to this. This is from Rockwood and Matson's The Shoulder. Think about the muscle, the innervation, the myotomes, and the technique for testing. We can't test a muscle in isolation. So, for example, if you're trying to test the rotator cuff musculature, the suprascapular nerve, which is C5, sometimes C6, the description is against resistance of external rotation. When we put the arm in a 90-degree abducted position with the palms flat, paralleling the floor, we're testing more deltoid. If we put their thumbs down in a pronated hand position, forearm position, then that does isolate somewhat the supraspinatus, but no muscle acts in isolation. So if they're very weak there, that gives you some information about the supraspinatus. In the thumb up or supinated position, more isolates the infraspinatus. So understand the innervation of the muscles, the trapezius and sternocleidomastoid, the spinal accessory, serratus anterior, the long thoracic nerve, deltoid, the axillary nerve, subscapularis, the subscapular nerve, supraspinatus, infraspinatus, the suprascapular nerve. Differential diagnosis of the shoulder. Again, the emphasis of making the primary diagnosis. There can be secondary diagnoses that occur. Think about the involved joint diagnosis, pathomechanics, and the most common sports. Glenohumeral joint, we think about instability. If it's bacrotraumatic, typically it's a unidirectional anterior direction. Labral tear as an overuse, throwing, weightlifting of a slap tear. You can think about the labrum as having different quadrants. That slap is the superior, anterior, and posterior quadrants, more symptomatic than the posterior superior. Instability anteriorly is the anterior, superior, and inferior. The classic Bankart lesion is the anterior inferior glenoid with a fracture. Subacromial space. In the older population or weightlifters, we think about this being a compression problem, where if the rotator cuff is not functioning, the space gets to be less, particularly in overhead lifting or throwing. So you have a compression problem from the acromion, clavicle, CA ligament above. In younger individuals, the problem is more of instability of the shoulder, and then you end up with a rotator cuff problem because it's a distraction problem, such as in throwing baseball, overhead tennis. Acromioclavicular problems, think about arthritis in a weightlifter, the weightlifter's shoulder of the AC joint. These individuals also have glenohumeral problems, mainly because of their sport of weightlifting and using the shoulder in a non-meant-for way. Neurologically, looking at the scapulothoracic articulation, think about the serratus anterior, long thoracic nerve involvement. We see this sometime in baseball and archery. Also, there can be scapulothoracic problems from multidirectional laxity or instability, underlying lack of strength in swimmers and tennis athletes. This is a gross dissection of a right shoulder. This shows the rotator cuff. We now have the scissors under the supraspinatus as it inserts, and the biceps tendon runs in a groove. A lot of action in the bicipital groove, biceps glenoid labrum anchor, and the supraspinatus. Clinically, it can be very difficult to tell which one of these is the primary diagnosis, so we make that diagnosis based on the history and physical of the patient. The primary diagnosis may change on follow-up visits, but make a primary diagnosis. Up above, you can see the fixed bony arch of the subacromial arch and the CA ligament. The rotator cuff is the sit muscle, supraspinatus, infraspinatus, and teres minor. These are the external rotators. There is a balancer or an internal rotator called the subscapularis, and that should not be forgotten. You can palpate the muscles doing manual muscle testing. Again, in the thumb down position, more isolates the supraspinatus, thumb up the infraspinatus at 90 degrees based on EMG testing. You can also palpate the most typical rotator cuff tears of the supraspinatus at its insertion on the greater tuberosity. If you rotate the shoulder, you can oftentimes feel crepitus and sometimes palpate a defect in the supraspinatus at its insertion. So internal rotators, external rotators. The internal rotators, the fourth part of the rotator cuff subscapularis is shown in the middle. Also the pectoralis major, anterior deltoid are internal rotators, and the latissimus dorsi and teres major. The external rotators are the sit external rotators, supraspinatus, infraspinatus, and teres minor. Rotator cuff testing. Empty can position, weakness in external rotation. So in the middle is your test for the supraspinatus, and on the right is your test for the infraspinatus. Again, if you really ask patients to fire muscles, it's not going to isolate one muscle. The deltoid kicks in. The test on the left is more palpating, rotating the shoulder. And if we internal rotate the shoulder, the space of the subacromial space gets to be less, so that can create pain. And if you have people with rotator cuff inflammation or even a tear, sometimes they will change the position of their hand, forearm, when they try to abduct on your command. And this is to try to reduce that compression in the space to avoid pain. The rotator cuff can be inflamed, it can be torn partially, completely. We can tell which parts of the rotator cuff are torn. Typically it's the supraspinatus. In grading the size of tears, a large and massive tear involved both the supraspinatus and the infraspinatus. The rotator cuff is like a sandwich in between two bony structures. The acromion clavicle CA ligament up top isn't moving, that's the roof. The proximal humerus is going to move proximal if the rotator cuff is torn and the deltoid takes over unopposed, so the humeral head becomes high riding. So you can think about this rotator cuff sandwich, if you will, as being an articular side on the bottom and a bursal side on the top. So is this more of a bursal-sided compressive problem? Is it more of an articular-sided partial tear of the rotator cuff, as we see in throwers, or is it a complete rotator cuff tear in an older individual? Complete tears can be compensated for. If the tear is well balanced, it can be like a suspension bridge, where the free side of the tear is the cable, and the attachments of the tear are the support on either end. So if you have a balanced rotator cuff tear, sometimes patients can have full range of motion. When we do rotator cuff repairs, we mobilize the cuff. These are traction sutures in the cuff, so we pull the cuff back down to the greater tuberosity. This individual is relatively young. You can see the great vascularity above in the bursal side, so you can see that bursal tissue on top of the wider taut tissue of the supraspinatus and the infraspinatus. So we mobilize this, and it's much like putting a window shade back down to a sill. We've made great advances in arthroscopic work on rotator cuff repairs. Most of them can be done through the scope, but at least now we don't have to detach deltoids and take muscles off of their origin. If we do a mini open, it's a deltoid split. It's very important to mobilize the cuff, make sure there is no further compression on the rotator cuff from above. And this also will allow you to do what work you need to do through the scope. So subacromial decompression, more to remove the bursa. The ligament is less rarely resected, only resected if it is frayed and definitely causing impingement of the supraspinatus. This is a 75-year-old with a massive rotator cuff tear. You can see on these plain x-rays in the outlet view on the left and his abducted attempted striker view that the proximal humerus is really articulating with the acromion. It is high riding because of the unopposed deltoid causing the humeral head to go proximal. If the rotator cuff had been working recently, there would be some depression of the humeral head and articulation with the glenohumeral joint, as opposed to now a new joint of the humeral head acromion. See some narrowing of the AC joint as well. So this is a classic example of x-rays of a proximal riding humeral head and a massive rotator cuff tear. When imaging with an MRI scan, these tears One must go far enough medial in the views to assess the amount of atrophy of the muscle, because this is very important if we are to know if we can repair the rotator cuff at the time of surgery. It would be very unlikely that this patient would be able to have a successful rotator cuff repair. Here is his MRI scan. The white is the fluid that leaks out of his joint. He has AC arthritis, and essentially now the humerus is articulating with the acromion, with the cuff retracted significantly proximal to the level of the glenoid. Full thickness supraspinatus tear. Images are getting better and better. Don't need an intra-articular gadolinium study for rotator cuff assessment, but you do need to go far enough toward the muscle of the supraspinatus and the infraspinatus on the axial and on FOSS cuts so that you can see the muscle. So I'll tell patients that the rotator cuff tears are like a window shade that is no longer connected down toward the sill. There will be increasing size of the rotator cuff tear over the course of years. It starts small, but with the origin still attached, there will be further retraction of the tear, and we do see rotator cuff tears that are massive, that are not repairable. So I think this is a good way to explain to patients what the problem is with waiting, and then in principle what you're trying to do is to put that shade back down to the windowsill. MRI scans are good ways to assess the size of the tear, the chronicity, and there are people who certainly don't come in soon enough for evaluation of their shoulder pain, and by the time we get them they have a massive tear that is sometimes not repairable.